Hello, everyone, and welcome to another episode of PodBites, your favorite podcast for breaking down complex medical topics into easy, bite sized chunks. I'm your host, Majd Hakki, and joining me today is Mohammad Lakser, also known as Rex.
Hi, Majd. I'm so excited to be here. Today's topic is all about the placenta, one of the most fascinating and underrated organs in the human body.
Absolutely. Let me give you some facts about the placenta. The placenta is a discoid organ that forms during pregnancy. It's actually the largest organ of the developing fetus, with two surfaces the fetal side, covered by the amnion and the chorion, and the maternal side, also called the decidual surface.
That's right, it's also stimulated by trophoblasts, which secrete beta HCG, and they help maintain early pregnancy by supporting progesterone production.
That's not all. Function wise, it does everything from gas and nutrient exchange, hormone production, to immune protection. A literal lifeline between two genetically distinct individuals.
So, today we're diving into placental pathologies and complications. We'll start with ectopic pregnancy, spontaneous abortions, and then we're going to move on to twin pregnancies, followed by preeclampsia and eclampsia. And finally, we're going to finish with gestational trophoblastic diseases like complete and partial moles, invasive moles, and choriocarcinoma.
Let's start with placental infections. These can cause serious complications like preterm labor or fetal infection. Will you give us our first case, Lakser?
All right, let's do it. So, I'm going to give you a case. A 24-year-old woman in preterm labor with fever, ruptured membranes, and foul smelling discharge. Ultrasound shows cloudy amniotic fluid.
Do you know what this sounds like?
What does it sound like?
This sounds like a typical case from an ascending bacterial infection causing acute chorioamnionitis.
Exactly. There are two routes of infection. There's the ascending, which is the most common, and then there is the hematogenous spread. Ascending infections usually come from the vaginal canal and can lead to chorioamnionitis and pneumonitis, and they can also lead to preterm birth. Do you know what can be seen in histology, Majd?
Of course, histologically you'll see neutrophilic infiltrates, edema, and congestion of the chorion and amnion, hence the name acute chorioamnionitis, as well as phonocytis, which is vasculitis of umbilical cord vessels.
Exactly. Now for hematogenous infections. It's important to note that infections such as torch infections, toxoplasma, other, which are syphilis, tuberculosis, and listeriosis, rubella, CMV, herpes, can transplacentally infect the fetus and often cause velitis.
Perfectly put. And that's it for our first case. Ali Bado.
Okay, let's go. A 30-year-old woman with abdominal pain, light bleeding, 6 weeks amenorrhea, positive beta HCG, but no intrauterine pregnancy and ultrasound.
Positive beta HCG and no intrauterine pregnancy on ultrasound with 6 weeks of amenorrhea. This is likely an ectopic pregnancy, where implantation occurs outside the uterus, usually in the fallopian tube.
Nice. So you sound like you're familiar with the concept. Can you tell me the risk factors?
Yes, they include PID, pelvic inflammatory disease, tubal surgery, endometriosis, smoking, IVF, also known as in vitro fertilization, and finally IUD, intrauterine device use. However, in about 50% of the cases, no cause is found.
Perfecto. Also to add, similar to our case, some key signs include pelvic pain, vaginal bleeding, and signs of rupture, like hypotension or shoulder pain. And for diagnosis, you need a positive beta HCG, an empty uterus, and adnexal mass.
Could you tell me more about the treatment of such a condition?
Alright, so for treatment, you will give methotrexate if it's unruptured, and surgery, salpingectomy, if it's ruptured.
Let's go. On to the next one.
Alright, so here's the case. A 36-year-old woman at 9 weeks with cramping, heavy bleeding, and passage of tissue.
9 weeks pregnant, cramping, and passing of tissue. This is definitely spontaneous abortion or miscarriage, defined as pregnancy loss before 20 weeks.
Exactly. And it can be further classified into early pregnancy loss or chemical miscarriage if it occurs before 6 weeks of gestation, or clinical spontaneous abortion if it occurs after 6 weeks of gestation. Now, what are some of the causes, Majd?
Most commonly, spontaneous abortions are caused by chromosomal abnormalities. Other causes include hormonal issues, infections,
Mhm.
uterine anomalies, lifestyle factors, trauma, and autoimmune disorders such as SLE and antiphospholipid syndrome.
Perfecto. And for diagnosis, you will need an ultrasound and histology for products of conception.
Hello. Could you tell me more about the treatment, Mr. Treatment?
So, with the treatment, there is the expectant management or medical management, which is the use of misoprostol, or surgical treatment, which is dilation and curettage.
Alright then. This is everything related to spontaneous abortion. I feel warmed up. Could you give me another case?
A 28-year-old has an ultrasound showing two fetuses in separate sacs, but has one shared placenta.
This is easy. That's monozygotic twins with monochorionic diamniotic configuration. For monozygotic twins, we can classify twinning based on the timing of the zygote split. Is that right?
Yep, exactly. That's a lot of big words, so let's break it down by the number of days to classify the type of the twin. If the split happens in day 0 to 2, it's dichorionic, diamniotic. But if it happens from day 3 to 8, it's monochorionic, diamniotic. If it happens from day 8 to day 13, it's monochorionic, monoamniotic. And if it happens after day 13, it's conjoined twins.
Okay, so let me tell you what I understood from those complex words. So first we have dizygotic twins. These result from the fertilization of two separate eggs by two different sperm. They're always dichorionic and diamniotic, meaning each twin has their own placenta and their own amniotic sac. Then we have monozygotic twins, or identical twins. These come from a single fertilized egg that splits, and the timing of that split determines how the twins develop.
Mhm.
Based on the day of division, monozygotic twins can be classified as dichorionic diamniotic, monochorionic diamniotic, and monochorionic monoamniotic, or even conjoined.
Exactly. You're on the right track. Wash Majd. Now into our next case. This one brings a surge in blood pressure and a few warning signs that might even be severe. Are you ready for it?
Yalla Haji, I'm more than ready.
Alright, let's go. A 35-year-old woman at 30 weeks with hypertension, edema, proteinuria, and right upper quadrant pain.
That's classic preeclampsia, caused by abnormal placental vascular remodeling leading to endothelial dysfunction.
Perfect. Now for complications, remember HELP syndrome with two L's. H is for hemolysis, EL is for elevated liver enzymes, LP is for low platelets, and if it causes seizures, we refer to it as eclampsia. It could also cause placental infarcts. Now, can you tell me, Majd, what will you find on placental examination?
Of course. So as you said, placental findings could include infarcts. They could also include retroplacental hemorrhage, villus hypovascularity, and fibrinoid necrosis.
Perfect, Mr. Sir. Those are pretty high-yield things to remember. Now, finally, your definitive treatment is delivery of the placenta. Until then, you must control the blood pressure, give magnesium sulfate to prevent seizures, and monitor closely.
Sahalat. Let's go to the one after.
Yellow. A 17-year-old with vaginal bleeding, large uterus for gestational age, and a very high beta SGG, and a snowstorm pattern on ultrasound.
A snowstorm pattern with large uterus for gestational age and a very high beta HCG. That's clearly a complete mole where you have an empty ovum and one or two sperm, 46XX or 46XY. All paternal DNA, no fetal parts.
Yep. Okay, what does the histology look like?
I like when you ask me about histology. Histology shows us hydropic villi, diffuse trophoblastic proliferation, no vessels, and a 2% risk of choriocarcinoma.
Perfect. And that one's done. Let's move to the next one. A 26-year-old woman comes in at 12 weeks of gestation for a routine prenatal visit. She reports mild vaginal spotting but denies pain or nausea. Her uterus measures a slightly small for gestational age. Beta SGG levels are elevated but not excessively high. Ultrasound reveals a fetus with a low heart rate and an abnormally thick cystic placenta.
That's concerning. When you see a fetus along with an abnormal looking placenta, especially with cystic changes, you should think of a partial hydatidiform mole.
That's right. A partial mole is a normal ovum plus 2 sperm, which results in 69XXY, a triploid. Fetal parts may present and the histology shows mixed villi, focal proliferation. Risk of malignancy is low.
Alhamdulillah. Now hit me with another case.
Okay, how about this? A 23-year-old woman presents 6 weeks after undergoing evacuation for a complete molar pregnancy. Initially, her beta HCG levels dropped, but now they plateaued and even started rising again. She also reports intermittent pelvic pain and light bleeding. Pelvic ultrasound shows a heterogeneous mass invading into the myometrium, and there's evidence of vascular invasion.
This is classic for an invasive mole. Persistent or rising beta HCG after molar evacuation should always raise a red flag.
Exactly. It occurs when molar tissue invades the myometrium or even enters the vessels. Often follows a complete mole.
And let's not forget, it presents with persistent beta HCG, pain, and bleeding which may embolize to lungs. Treated with chemotherapy.
Nice. All right, last case.
Hakki.
Let's go. This one really highlights how aggressive GTD, gestational trophoblastic disease, can get. A 28-year-old woman presents to the emergency department with shortness of breath, hemoptysis, and persistent vaginal spotting. She had a complete molar pregnancy, evacuated 3 months ago. Her beta HCG is extremely elevated, over 150,000, and a chest X-ray shows multiple cannonball-shaped lung nodules.
Oh wow! That's a classic presentation of choriocarcinoma. When you see respiratory symptoms, high beta HCG, and a recent molar pregnancy, you should think of metastatic GTD, gestational trophoblastic disease, until proven otherwise.
That's right. It's a malignant tumor with cytotrophoblasts and syncytiotrophoblasts, but no villi. Highly aggressive.
It also follows complete mole, abortion, or even term pregnancy. It spreads via blood to lungs, liver, and brain, but has an excellent response to chemo.
ما قصرت مجد.
Thank you. Whoa, we covered a lot today, from placental infections to moles and malignancy.
Yes, we did, my friend. Yes, we did. And as a quick summary of what we covered, ectopic pregnancy means implantation outside the uterus.
Spontaneous abortion means early loss, and it's mostly chromosomal.
Twin gestations, we have di and monozygotic.
Preeclampsia, showing hypertension and proteinuria due to endothelial dysfunction.
GTD, from benign moles to choriocarcinoma.
Alright, one final question before we wrap this up.
All right, quiz time. A 19-year-old woman presents with rapid uterine enlargement and extremely elevated beta HCG. Ultrasound shows a snowstorm appearance with no fetal parts. What's the most likely diagnosis? I'm going to give you choices. A, partial mole. B, complete mole. C, invasive mole. D, choriocarcinoma.
And the answer is B, complete mole.
Bingo.
Thanks for tuning in. Don't forget to follow us for more bite-sized medical breakdowns.
This was PodBites, helping you learn medicine one conversation at a time. Catch you in the next episode.
See you next time.